Okay, thank you very much, Dr. Athir. You're still awake, I hope, because we're going to show you some data here. I'm a bit short, so I can't see that much, but anyway. So I work in Tawam. This is the entrance to Tawam Hospital, one of the secondary or tertiary, it depends if it's oncology. You're welcome to visit us in Al Ain. It's a very nice area, quiet area. This is my disclosures. So as from the last slides of Dr. Athir, that there are so many cytokines working in rheumatoid arthritis. The pro-inflammatory and the one which is non-inflammatory, and we need to balance between those. This is why baricitinib is not a biologic therapy. They call it target DMARDs, because it doesn't stop one cytokine. It can stop a lot of cytokines, which I will show now. So these are the cytokines which use, they are pathogenesis of RA, so many cytokines. And by blocking the JAK, using the JAK inhibitors, you can block all these cytokines, including interferon. You can say, where is TNF, which is the big guy here in RA? Where is it? Well, through interferon, and I take that from one of the lectures I attended, interferon indirectly blocks TNF. So it doesn't block TNF, plus the IL-16. And you can see also there's a blockage of some of the cytokines which works in psoriasis and psoriatic arthritis. So we go to the studies. It's 37 countries, about 3,500 patients being involved. And so many studies the Lilly has done. The RA Begin, whereas you have an arm of monotherapy. The RA Beam, which is, we'll talk about it, we'll concentrate on that, and the other studies later. We'll just go through quickly. So the RA Beam study, which is the one done to show non-inferiority as well as look at maybe superiority to adalimumab. A typical patient, a female in about 50s, very active disease, who failed 2 to 3 conventional DMARDs. And they are 1,300 patients, were just 2 3 arms, placebo, methotrexate and baricitinib 4 milligram, and methotrexate plus adalimumab. And the results were really interesting. You probably saw these slides many times before. We'll talk about it again and remind ourselves that that's the only drug which shows superiority to adalimumab, as far as I know. So the p-value, which is not showing that much here, the plus is the p-value compared to adalimumab, which is statistically significant in all. In week 12, 24, you have it here, in 70, and also in the ACR 20, 50, you can see it's significant, statistically significant. The others, although it wasn't statistically significant, it was numerical significant. And of course, compared to placebo, is a way above. And you can see about 70% has reached in ACR 20 and 19% of the ACR 70. And if you take the other studies where they compared, of course, to placebo, this is the study where they use methotrexate, of course, plus baricitinib, and methotrexate plus placebo. This is for irresponders, conventional DMARDs irresponders, and you can see significantly compared to placebo, similarly to the TNF. We know from most of the studies, even in the biologics, that when patients try TNF and you use other TNF or other biologics or JAK inhibitors, the numbers are lower, but you still have a good response here and with a statistically significant. Look at the DAS score. Dr. Athir has shown that in Europe, maybe المصريين يقولون نفرطها يعني they divide. So the ACR take everything. Here we take the joints. Mainly we concentrate on the joints using the CRP. And again, you have a statistically significant compared to the adalimumab. Of course, it's compared to the placebo is known. The shaded one is the remission, and the colored one is the low disease activity. And you can see it's better than adalimumab here, numerically better here. And in the week 52 in the ACR, and the DAS 28, sorry, CRP, it was also statistically significant, but not in the ESR1. Looking at the S-die, C-die, as C-die, Dr. Athir said, it's more maybe represent the patient's towards the rapid 3, and again, you have a significant compared to adalimumab. So it is superior to adalimumab, which is interesting. And that's shown against placebo in the responders, conventional DMARDs, and in TNF responders. Again, the numbers are lower, because when you use one drug or two, maybe the response less, but again, you have a significant response between baricitinib and, of course, placebo, adalimumab not here. Now, if we look at the patient, PROs, reported outcomes, we concentrate on the pain, fatigue, return to function, and of course, physician, we are concerned about DAS and X-rays and erosions. And if we go to pain, I think maybe Dr. Athir has shown that. Again, baricitinib shows superiority in reducing pain compared to adalimumab, and of course, speaking about placebo, is significantly lower. And that's when you see a p-value, it's not showing there, I'm sorry, but it's again, statistically significant. Then if you look at the DMARDs responders, you can find 4 and 2 milligram works the same, although here in TNF responders, 4 milligram was better. I'm not sure if it's significant compared to 2 milligram, but it's definitely significant compared to placebo. Looking at the HAQ score, the same. I don't want to keep repeating that, and it's the same in responders and in TNF. So you have a drug which is superior to adalimumab, works on what we want as doctors, DAS score, ACR, erosions, which I will show in a minute, stopping erosions, and of course for patients works on pain, HAQ score, and which including returning to their normal life. Then we look at of course, the Van der Haag, the SHARP score, and of course, here there is no significant compared to adalimumab. Maybe you need more years to show significant, but it's numerically better. However, it's really statistically significant compared to placebo of stopping erosions. So I included a case which I was asked to, and I will go quickly. I don't know how many minutes I have. You finish about 14, so I'm supposed to be 33, 34, okay. This patient who I shared with, I know Walid ran away. Oh, there he is. You here, huh? You here? Okay, so this guy was reported to be from Walid. He always refer patients who are difficult. Not difficult cases, difficult for asking medical reports for 600 times, yeah? So this guy is a seronegative. There was supposed to be possible sacroiliitis. He had pain all over the joints. He's complaining of back pain, knee pain, everywhere. I have to say, I wasn't convinced he had RA at the beginning, not questioning my colleague Walid, but because maybe he was treated well. And he took a lot of drugs, infliximab, I think adalimumab, methotrexate, I don't know whether sulfasalazine. But he came just with a lot of pain. I did MRI SI joints, which was normal, reported normal. Then I nearly told him, you don't have inflammatory arthritis, because he was pushing for a medical report. But I usually sometimes do isotope bone scan, which is quite sensitive to pick up things. It's not specific, but it helps me. I do use it in England a lot for fibromyalgia. When if it's negative, I will tell them, you have nothing in your joints, go away. Go to pain clinic, sorry. But my colleague Walid, he loves ultrasound. He kept sending me videos about his joints, and he had inflammation. And the isotope bone scan showed multiple joints inflammation. And it was asymmetrical. Anyway, treated before with all these drugs, so we decided let's go with the tofacitinib, XR. He responded, but his liver enzymes shoot up high. So I stopped it, restarted it, ALT went up. And I said, listen, you have to be, I'm going to ask you privately. You don't booze, do you? You don't drink a lot, do you? You don't get any boozing from me. He said, no, wallahi, I didn't touch alcohol. So we stopped it, and I moved him to baricitinib because, and of course that's shared with Dr. He goes to Walid and he comes to me. Me for medical report, Walid for decisions, I think. But at the end of the day, we said, let's give him baricitinib because it's a bit safer on the liver, that's what we know. Until a few weeks ago, I did an ultrasound scan done by the radiologist, who was a musculoskeletal radiologist, because you know this guy, the minute you scan his foot, he said, can you scan this, can you scan that, can you scan this, can you scan that? And you end up 40 hours, I think. I don't know how well he's doing it, but he actually we can see this is on baricitinib, and we can see his CRP, and he has no inflammation. Back to the studies. Now we have a study called RA Beyond. I still have 7 minutes, I can't think. RA Beyond followed all these studies, Begin, Beam, Build, Beacon, for 4 years. It's still going, but we have data for 2 years. So the RA Begin, that's really interesting that the first company who took the risk and used monotherapy compared to methotrexate and barrier. Yes, the numbers are, I think it's okay, the numbers not compared with the others. And you have the RA Beam, which I talked about, and then you have the Build, where it's the responders to the conventional DMARDs. And they looked after 2 years about the erosions. There's no, of course, much better than placebo, consistent erosions or joints narrowing. And that's consistent for 2 years, as we can see. It's not different to the adalimumab, the RA-Beam, as I showed, but it's statistically significant compared to the placebo. So a drug which works, this is plus methotrexate. Don't take it as monotherapy here, of course. Now, we need now a drug, it's superior to adalimumab, showing you can use it monotherapy, as the EULAR guidelines says, in JAK inhibitors. Now we need a drug which is safety, and the very common things as other biologics and these drugs which block cytokines is infection and some hypercholesterolemia, which we can talk about of the monitoring at the end. The rest is not that common. We'll talk about it. So concentrate on this. Now, DVT is something important here. We all worried about JAK inhibitors now, as even tofacitinib had a red flag. But the company was very clever in showing that the RA patients themselves have a higher number than patients taking JAK inhibitors and getting DVTs or thrombotic events. You may ask, okay, RA has a thrombotic, you add baricitinib, they will have more thrombotic. No, probably not, because the RA probably due to the disease activity, and if you control disease, you will reduce that risk. But anyway, it's less than the RA itself. So the RA patients themselves have a higher risk of thrombotic. And if you take the overall, this is just 0.5 risk per patient, per 100 patient exposure, which is, and it's consistent all over the years they did. So yes, there is a red flag. Yes, we should avoid it in some patient with thrombotic, or be careful when we use it in a high-risk patient. But we can tell them, and we can be sure that it's not, as it shows here, it's consistent. If we look at the DVT, it stayed for 30 months update. So 12 months, 19 months, and 30 months update. No change here. The major adverse cardiovascular events and serious infection, nearly the same. It's consistent, no change over the years, which is reassuring to us as a rheumatologist. The last study, which I still have 4 minutes, I think. Yes? Are you watching? Okay. So the last study is they looked at, can we step down some of the medication from 4 milligram to 2 milligram? So they took patients, stayed in remission for 15 weeks, and then they kept one arm 4 milligram, and they moved to 2 milligram. Patients all had methotrexate 15 milligram, mean dose. And you can see they are in remission or low disease activity according to the DAS or CDAI. Results, again, it's good, okay. If you stay on 4 milligram, there is a statistical significant drop, maybe you can tell it, but if you see, it's only about 10%. So you can still maybe save the patient taking 4 milligram. Yes, 4 milligram is better, but you can drop if your patient is doing well. I think price-wise is less, yes? Yes, no, no, yes? The same price? Well, you're not saving money here. I don't know, maybe saving risks here. But anyway, although dropped is only about 10%, which is, and this is again remission, and that's low disease activity. But you can see over the weeks, there is statistically significant drop, but numerically is only 10%. So, what do you need to do? This is not only for baricitinib. This is just an advice. For biologics, all of us as a rheumatologist, we have to screen. Yeah, for biologics, we in Cerner now, Tawam, and all Saha Hospital, we have a screening for biologic tool where we screen everybody who want to start biologic or JAK inhibitors for TB, HIV, HCV, hepatitis, and I'm sure this is a practice all over the Gulf or all over the world. Maybe be cautious in patients with thrombosis. I have 2 patients actually who have DVT and they wanted to continue on the medication. Not after I started, they already had because they take warfarin. Use anti-TB as you probably know. Now for the lipids, as we said, you can do 12 weeks after starting and then according to guidelines. For white cells, you have to check the neutrophil, lymphocyte, hemoglobin, liver enzymes, of course, kidney function as well, before you start. Now, if the lymphocyte below 0.5, then you should not start, as well as the neutrophil below 1,000, you should not start. Hemoglobin below 8, also you should not start. Creatinine, it's not studied in less than 30 GFR. And if there's a severe liver disease, again, you don't start. But as I showed, it's probably safer than tofacitinib. Right, in summary, so I showed you that baricitinib selective JAK1 and JAK2, as Dr. Athir also mentioned that. It's for patients with moderate to severe active RA who are insufficiently responding to other DMARDs or even biologics, clinically tested in nearly 3,500 patients with an acceptable benefit risk profile, more than 10,000 patient years with up to 7 years exposure. I showed you that baricitinib plus methotrexate demonstrates significant improvement compared to adalimumab, so it's superior. I showed you baricitinib showed rapid and sustained efficacy that starts working as early as 1 week. I didn't mention that. It's a fast action. As early as 1 week, you can see that, and we saw that in our patients. Baricitinib demonstrated an inhibition of the joint damage, as most of the biologics, but it was significant. So you need a drug which has 3 major trophies, yeah? Safety, rapid action, superior to adalimumab, safety, and patient like it, which these are the targets, yes? Those for who doesn't love Liverpool, you can put your head down, okay? So we have 3 targets in 1 year, and we're hoping for the 4th one and the 5th one coming. Yes, Waleed? Yes? Yes? Yeah? Yes, these are the superior to the guys who lost 4-3 in 2 days. It's back to Dr. Athir. Thank you very much. Thank you for listening.